I didn't.
Yeah, that's also coming, but we have. Husband's coming, but we have.
Oh, yeah.
All right. Good morning, everyone. It is 9:04. Let's bring today's meeting. Let's go ahead and start it. Can we do roll call? JLMBC, the meeting, the JLMBC meeting. We are bringing the August JLMBC meeting to a start. Can we start with roll call?
Good morning, everyone. We will take roll call starting with management, then the employee organization. Malika Billups. Tony Royster.
Here.
Matthew Rudnick.
Present.
Paul Gerard for Matthew Sable.
Present.
Patrice Latimore.
Present.
Janita Igueler.
I am here, kinda.
Marlene Fonseca.
Here.
Chad Boggio.
Here.
Esteban Lizardo. And Lisa Palombi.
Here.
We have quorum.
Awesome. We'll open it for public comment.
At this time, we will take public comments. If you are participating via phone, please press *9 and announce yourself. If you are in the room, please drop off your speaker card now. We have no public speakers for today.
All right, we will move on to the action item. Can we get a motion to approve the minutes from June 4th, 2026?
I move. Second.
Okay, we will take, sorry, we will do the roll call for votes right now. Malika, your vote. I'm sorry, Malika's not here. Tony, your vote.
Aye.
Aye. Matthew, your vote.
Aye.
Paul, your vote.
Aye.
Patrice, your vote. Janita, your vote.
Aye.
Marlene, your vote.
Aye.
Chad, your vote.
Aye.
And Lisa, your vote.
Aye.
The vote is unanimous. The motion passes.
Awesome. Okay, we will go to our next action item, which is committee report to 617 LA Well Program 2027. Medical service provider premium rate final results. Good morning.
Good morning, everyone. Paul Mikowski, Employee Benefits. JLMBC members may remember from last time we met back in June, and we presented the full 2027 plan report for adoption. Part of that report was the medical premiums for 2027, where we noted that the rates themselves, at least from two providers, were provided with information or claims data, which was identified as being a little bit immature for the actual claim providers themselves. And so they were widely using prior data from Anthem, which kind of created a little bit of skew in what we were expecting the rates to kind of look like. So there was a recommendation at that time for us to set those rates, but then allow us to still negotiate or to still talk with the providers under the concept that they would get additional claims data and be able to reevaluate their rates based off of the larger set of experience. So from that time when we met back in June, we have been doing that. And the end result of where we're at today has not really changed. So Keenan's going to talk us through what the experience is, why that result happened, why we have not seen a change from providers. In addition to that, just recently, a few weeks ago, there was a tax that was initiated by California called an MCO or Managed Care Organization tax, which we're also going to talk about on its implications potentially for 2027 or 2028 and beyond. But first, we're going to talk about experience. So let's go ahead and pass it over to Keenan to go through attachment A.
Good morning, JLMBC members. Thank you for having us here today.
We have before you a deck that kind of puts all the plans together in one spot, kind of a one-stop shop, look at how the medical plans and the ancillary plans are running. Oh, so sorry. Thank you. This is kind of a new report that we hope to kind of continue to bring back and show you kind of a year over year or period over period look. So you can see how the plans are actually running. But in general, Jillian's going to talk in detail today about the medical plan experience and other plans, but it is generally stable. To Paul's point, the carriers are brand new carriers, specifically Blue Shield and UHC. They have very limited data. Their plans are considered immature at this point. And we'll talk about what that means on a plan by plan basis. We are seeing some large claimant activity across all plans. That includes Kaiser, who is obviously not a new carrier, and costs do continue to increase. We've also included some demographic information, and that's important because we're seeing some concentrations in specific plans, and then it's also important for you to understand how that drives in terms of rate setting. And then we have a little bit of color on pharmacy as well. Pharmacy continues to be a cost driver, especially in the specialty category relative to GLP-1s. And then we had some call outs on some potential cost drivers in steerage and education pieces that we can talk about in terms of urgent care eligible ER visits and the like. We have some mixed results across the ancillary, and we'll talk about that. Some of the plans are running well, others are in rate guarantee, so we just want to keep an eye on how they're running. And then we got a little bit of information on utilization for the EFAP program itself. That program was just recently extended. However, we're looking at RFP options and a couple other things that the insight that we're gaining is going to help drive how that RFP runs. So just a little bit about that as we kind of jump into this. I'd like to go to what page is this? The demographic slide. One more, please. There we go. Just want to call out that this is point in time data. This information is subscriber demographic data. Jillian's going to talk about member data, and that includes dependents, which is a slightly different look. And it's also going to be broken out by plan, but this is just kind of a high level in terms of where your population and your membership is enrolled, with Kaiser remaining the majority of enrollment on the plan, followed by Blue Shield and then UHC. We do have a very small population enrolled in the new high deductible health plan. That's very typical for a new plan, especially one that is so very different than the rest of your normal plans. And we typically see that grow over time. Your population age in terms of your subscribers, average age, running the gamut between 45 to 49. And just in terms of the demographics and shifts that happen across the plans and, retirements and hiring and the like, obviously that will impact the demographics across the enrollment by plan, but definitely want to take a look at what the member data looks like as well. So we're going to jump now into kind of the actual utilization. Jillian, I'm going to turn it over to you.
Megan, good morning, everybody. I'm Jillian Turner, Vice President in Keenan's Benefits Underwriting and Actuarial Department. As Megan mentioned, I'll be providing a little bit more detail on what we're seeing so far as far as utilization and plan performance through April 2026 and comparing to the prior period, which is May 24 through April 25, where possible within the report. One thing to note is that the Kaiser period is slightly different due to the cadence that their reports are released to us. So their time period there is February through January. Moving on to the next page, we have a high-level summary of plan performance for all plans and then combined on the non-Kaiser side and then Kaiser separately off to the right. Presented here, we have your loss ratios, which are claims and capitations in comparison to the premium that's collected by the carriers. Typically for your for your non-Kaiser carriers, we like to see this loss ratio between 85 and 90%. Kaiser, due to its budget-based model, has a slightly higher target loss ratio of around 93 to 95%, depending on the group. So looking at that top line year, PYTD, that's your plan year to date, January through April. Plan performance, current 12 is May 25 through April 26, and then prior 12 is May 24 through April 25. So Anthem doesn't have any year-to-date data since all we are seeing is run out from them. But their current 12-month period was running a little bit over 100%, likely due to increased utilization towards the end of the plan year after the announcement of the carrier transition. Year-to-date and current 12 figures for Blue Shield and UHC are the same because we only have that 4 months of data available to us. And then we have a combined look in the orange shaded sections that combines all carrier data together versus the premium collected. So plan year-to-date running right about 100%, current 12 months, a little bit over 100%, your prior 12 at about 97%. And then when we look at the combined per employee per month cost, that's what PEPM stands for there. We can see that on a cost basis, we are trending up a little bit plan year to date versus the current 12 months as well as the prior 12 months. On the Kaiser side of things, running around 98% through April, running at 96% for the most recent 12 months, 97% for the prior 12 months. Looking at the next page here, you can see in that top chart, that's a breakdown of costs by carrier. So the maroon shading is Anthem, which you'll see start tapering off as you go into 2026. And then blue is UHC, green is Blue Shield. So majority of plan costs coming from the Blue Shield side of things, not surprising given that that's where the PPO plan is, which tends to generate higher costs in general, followed by UHC, and then eventually that Anthem maroon shading will disappear from the graph once the run out completely tapers off. In terms of cost by type, the bottom chart there represents just Blue Shield and UHC and Anthem data. You can see that the majority of plan costs are attributable to medical costs, followed by capitations in that lighter shaded orange, and then your pharmacy costs in gray. One thing to note there, in terms of Blue Shield and UHC in comparison to Anthem in the prior periods, is that we have seen a pretty meaningful decrease in pharmacy costs, PEPM. Your capitations have went up slightly, and then medical costs are remaining about similar to what they were previously. So hopefully that's a trend on the pharmacy side of things that we continue to see in future months. Moving on to the next page, as Megan mentioned, we do have some member demographic breakdown by plan. Your average age and average contract size, meaning the average number of dependents that are enrolled per subscriber, are in that top left section, followed by your gender mix on the right-hand side. Key things to note in terms of demographics by plan is that we're definitely seeing what we call adverse selection on the PPO side of things. Very expected given that it's a richer plan and those that tend to enroll in it intend to utilize it. So we are seeing a higher average age there and a lower average contract size, which is a function of the way the payroll deductions are set up with the city being most generous on the singles and less generous on when there's dependents enrolled on the PPO plan. We are also seeing the highest average contract size on the UHC signature value full plan, and then the highest average age, again, is with the PPO. In terms of gender mix, when we bring the dependents into the equation, it splits more to 50-50, whereas when we look at it on a subscriber basis, the population is more heavily male, about 60-40. And then that middle bar chart there is just your distribution of costs broken out by site of care. So inpatient, outpatient, professional. Capitations will always be probably the largest piece of the pie when broken out this way, just because we have a lot of HMO enrollment. One thing that we've noticed is really driving costs within the first few months of the plan is the high cost claimant activity that we're seeing on the Blue Shield side of things. It's been very quiet on the UHC side of things year to date through April, but we do have on the Blue Shield plans, 12 large claimants thus far exceeding $250,000. 3 of them are actually over $1 million. 2 of those 3 have since terminated from the plan. They're no longer enrolled and haven't elected COBRA as of what we can tell in the data thus far. So that's good from a plan performance perspective, but the claim spend is still there when we go to look at renewal come next year. All in all, those claimants over $250,000 represent about 20% of your total plan spend, which is actually a little lower than what we typically see for groups. Typically, it's about 70-30, 60-40 in some groups that have lower levels of participation. So though there is a lot of spend coming through those 12 members, it is in comparison to what we typically see actually a little bit lower.
Can I ask a question before we get too much further into
Sure.
the slides? Scrolling back just a second to the PEPM cost by type, and you
Mhm.
mentioned that the pharmacy is the gray and that it's been lower the first few months. We've heard at some of our meetings that one of the biggest complaints is that the formularies are so different that people are having a hard time switching over to a new kind of brand of pharmaceutical to replace something that had been covered previously. Could that explain the sudden drop in pharmacy utilization?
It certainly could. It could also be attributable to oftentimes when members know a carrier change is impending, they kind of stock up on their prescriptions. So that's why December's pharmacy spend is higher than all the months preceding that. So it could be a temporary decrease and it could possibly also be attributable to that. I think we would hope that members would continue to pursue a way to find their medication. There's therapeutic equivalence if the exact prescription is not on the new formulary. So that's certainly something we can take back and work to communicate better
Thank
to
you.
the members.
Actually, you're done with the slide? Let's see, the large claim overview slide?
Yes.
Because I had a question about that one. So when it says all other, is that just any claim that's not a large claim?
Any claim that's under 250.
Okay. So UHC hasn't had any large claims?
No, the largest large claimant listed on their report was $218,000. So they did not make it onto this report.
So is there a way for you guys to know, or do you know why Blue Shield would have such a high percentage?
11 of those 12 claimants are on the PPO plan, so it's what we would expect. I don't know that we would expect that many within such a short period of time, but we would definitely expect higher prevalence of high cost claimants, given that the PPO plan is a plan that has less restrictions, no gatekeeper, out of network benefits. You can kind of go to any doctor that you want. And then also on the payroll deduction side of things, it's a higher cost for employees. So those that are enrolling in it are intending to use it most times. So it's very common to see what we call adverse selection on PPO plans when there's HMOs in play.
And that's all I think.
Next slide is just a little bit more detail on those high cost claimants. On the Blue Shield side, you can see that the vast majority of them, except number 6, is coming from the PPO plan. 3 of the top 5 have terminated from the plan, and you can kind of see the diagnosis information there of what some of those drivers are, most of which are fairly common in what we see in terms of cancer diagnoses, metabolic and endocrine disorders, and related complications, heart conditions, things like that. So the bottom chart there just is an example of how when the renewals are underwritten that we track these based on the Blue Shield pooling point, which is 525,000. That's kind of how we develop our monitoring level, which is half of that. And so this will give you an idea of how when the renewal is underwritten next year, some of these claims will be forgiven because they're in excess of that pooling point. All right. Moving on to Kaiser, as mentioned, the time period for this one's slightly different due to the availability of their reporting, but the main idea here is green is good, red is bad. So we break down the utilization based on category as well, inpatient and outpatient. There's a separate page for pharmacy, but you can see, generally speaking, demographics have remained pretty consistent. That's going to be what's in your box on the upper left-hand corner. To the right of that, you'll see your claims broken down by site of care and type, trending at about 5% higher than the prior period and above Kaiser benchmark. From an inpatient utilization perspective, we're seeing favorable trends in all categories with the exception of average length of stay, which has went up by about 11%. This can easily be attributed to a single patient having a very lengthy length of stay that kind of skews that data a little bit. And then on the outpatient side, which is that bottom left part, That's a little bit of a mixed bag. We have some unfavorable trends in mental health, emergency room surgeries, but then some neutral trends, which you see in the yellow. Overall, the inpatient PMPMs went up about 10% and is also above Kaiser Book of Business norm. And then over in the graph on the right, you can see the breakdown of cost by category in comparison to Kaiser's benchmark on the far right. Right. And then on the pharmacy side of things, the pharmacy PMPM's up by about 10%, current versus prior. It's largely driven due to an increase in the brand PMPM, which is not too far off from benchmark. Benchmark's about 50, current period's about 55. Both generic and specialty are also well within benchmark range. Cost per scripts remain pretty stable, but we did see an increase in cost per script on the specialty side of things. Again, because there's so few scripts, this oftentimes can, relative to brands and generics, oftentimes this can be driven by one or a few new medications coming onto the plan. And then your generic utilization rate, that is the number of people that are filling a generic when a generic is available, is around 91%. Formulary compliance rate, that's your members that are choosing a brand formulary drug versus one that is non-formulary. They have both remained relatively steady and they're right on benchmark with Kaiser. I'm going to pass over to Megan to talk about ER and GLP-1s.
In terms of the plans, one of the things that we are kind of looking at and monitoring and called out last year was an opportunity for steerage and education for urgent care eligible ER visits. And what that is somebody who ends up in the emergency room for something that might have been able to be triaged at an urgent care facility. So this is something that we're kind of keeping an eye on. We have data from Blue Shield and UHC, again, understanding that it is immature and it's based on a limited amount of data set. But Blue Shield reporting that on the PPO plan, about 55% of their ER visits could have been directed to a non-ER setting, and on the HMO, about 59%. On the UHC side, it's a little lower at 31%. And noted that we are working with KP to kind of tease this data out. It's not a data stack that they have readily available, and we'll talk with them about their reporting to see what we can get there and report back. But this definitely is an area where perhaps an education campaign for members or maybe a mailer to alert them to where their local urgent care facilities actually are might help in terms of steerage and understanding where they can get their care and navigate that accordingly. But this is definitely something that we want to monitor year over year and provide some information to you so you can help understand what's kind of driving there, because it is a cost driver on the plan. And then when you're talking with your membership, just remind them urgent care is also a great place to get their care and coverage is available to them there.
So what, I mean, are the plans doing anything to, or are the carriers doing anything to try and educate our members on this should have been something that's in
Yeah.
urgent care? And I guess too, is what determines, like, what is the threshold?
Yeah, and that's a great question. And so it's definitely a conversation we're having with them in terms of planning mailing campaign and talking to those folks. It can be hard, and this is why Kaiser, it doesn't have the data readily available. Is initial diagnosis that's coded when you go into the ER sometimes isn't what ultimately ends up being the diagnosis or what they're treated for. So it can turn into a gray area depending on what's happening with the member. And talking with Paul, he had asked, can we tie this back to kind of like high cost claims and have that overall holistic look? And the carriers, obviously that presents some privacy challenges. So that is hard to look at, but it does beg the question in terms of what's happening with members and why they end up in the ER to begin with. Sometimes they may start at an urgent care and then end up in the ER, and because of steerage for a lot of reasons by urgent care staff. So it can be quite a complex issue. And obviously we want folks to get the care that they need at the time that they need it. But in terms of educating members, working with the carriers to let folks know where those urgent care are, 24/7 nurse line resources and things like that might be good resources for them when they're determining what their medical need might be. And so as we're continuing to look at this and having those conversations, we're going to talk with them in the city about what the needs are in terms of educating members on it.
Because when we look at United Healthcare compared to Blue Shield, it's like one is almost double.
Right.
The other, do we know like what that is drivers? Do we have any information on like?
Not yet, not at this time. Again, the data, it is immature data based on what we have and what we've seen. And as we get more data, it may level set, it may normalize, as it were. It could be that it could be a geographical location in particular. Like, we just don't know yet in terms of what that actually is. As we get more data, we'll be able to tell and have more appropriate data sets and steerage and what that could look like. But it is immature. That has been the challenge with the new carriers, is the data is very limited.
And I think just to add on to that, sometimes carriers don't always measure things the same way. Blue Shield may measure something different than Kaiser, or different than United Healthcare, for example. What might be avoidable under UHC is not, or something that Blue Shield doesn't, or vice versa. So that could play a part, and also that adverse selection that we talked about earlier as well. That could also be playing a part.
Yeah, Mike.
Do we know if they have comparable urgent care availability? Meaning, with some providers, it's very limited. You have a wobbler of a case, well, the hospital is 2 minutes from the house. For urgent care, for me, is at Woodland Hills with one of the providers. So,
That's absolutely something that could be the case. We do know that there's a lot of overlap in network, but it is, to your point, based on what your need is and the actual locations that might be available.
or the hours are.
Exactly, exactly. I can tell you, my kids don't get sick between 8 a.m. and 9 a.m. Never, never. It's always 10 o'clock at night, and it becomes an issue. So that is a driver. In terms of GLP-1s, this does, on the pharmacy side, continue to put cost pressure on every plan that is out there, not just the cities. We got a little bit of color from each of the carriers as to what they're seeing. Certainly GLP-1s for those who need it for comorbidities such as diabetes and sleep apnea, heart conditions. I mean, those are the folks, they are getting what they need. Where we become concerned is those that are utilizing for weight loss. There have been moves by carriers to kind of help gatekeep and curb that and limit things. And here in California, the change in a BMI from 30 to 40. And so there is some gatekeeping that's happening. But the marketplace for GLP-1s itself tends to still be unstable. There's a lot happening out there. We have emerging technologies and GLP-1s that are coming out at the pill form and versus injectable. Pill just being approved by the FDA and released to the market is certainly driving things. There is a new kind of mix of GLP-1 that is coming on scene. It's called retatrutide. It's supposed to be better than, regular tirzepatide. So that is happening. And then you have obviously the direct to consumer options. And so there's just a lot that's happening out in the GLP-1 space that continues to make it very volatile. But it is something that we're closely monitoring. Obviously, the carriers are also watching this and monitoring the utilization thereof. But keeping an eye on this and what the spend is definitely good. Due diligence on our part and part of the plans to kind of monitor what is happening in terms of specialty spend.
Is there any way that we're measuring if there's like a return, like what the return on investment is in GLP-1, like when it comes to just other like health issues and health and costs?
Yeah, it's something that we're starting to get that request quite a bit on. We need to sit down with the carriers. Again, obviously the challenge being with the data, limited data with Blue Shield and United Healthcare. But that's something we want to keep an eye on and certainly take a look at in terms of how that is looked at for return on investment. I think it's definitely a conversation we're going to have to see what their reporting capabilities are, because bucketing somebody who has a diabetic need is very different than somebody who is pre-diabetic or has sleep apnea or who is purely doing it for weight loss. And we know the long-term benefits of keeping weight under control, and that takes a long time to measure and come up with an ROI. So there's some complexity there. It is certainly something that we are starting to see out in the consulting space with mixed reviews on what that ROI actually is, but it is, I think, a little early for us to tell specific to the Blue Shield and UHC plans, certainly, but definitely a conversation that we're having with them.
And then I guess this last question. So with UHC, it looks like their Harmony plan has like a lot higher. Is there a reason for that? Is it because of it's more, well, yeah, why is the Harmony plan having?
Yeah, so it just depends on how it is that the plans are, when certainly the contracts that they have under the plans in their pharmacy. And then also in terms of who's utilizing this. We saw across Anthem kind of a bucket. And when the plans came on scene, we saw a very much an intentional plan selection based on where folks were getting their care prior. So the Vivity plan and the plans, the providers that were within Vivity, higher cost, and those folks generally went over to the UHC plan. So I think in terms of who's actually on the plan and utilizing and where they're utilizing plays a role in that. In terms of the pharmacy cost, well, let me take a step back. The plan design itself is the same across the board. So in terms of what the city's copays, that is all remains pretty steady and stagnant, but the contracts that the carriers have differ. To Jillian's earlier point, they handle things differently. Their PBMs and their contracts are a little bit different. So in terms of cost and spend, that's why you're seeing probably a little bit of differential there. Anything to add there? Yeah.
I have a question.
Yes, ma'am.
You mentioned BMI earlier. Is there a point for the folks utilizing this drug for weight loss that is there a threshold where they're done with it, or is it
Yeah, I think
endless or?
a lot of the carriers, there's a couple of things on that front. There is with GLP-1s, some of the gatekeeping, like when you first start on it, you have a BMI that you have to meet. And certainly if there's other comorbidities that might be in play, the BMI might not be the driver for the reason as to why they're on it. So it is a process by which when the treating physician goes through a recertification and touch base and monitors a patient. So while BMI might be one of the reasons why they're on it, a comorbidity might be a reason why they stay on it, even if they get under the BMI threshold, if that makes sense.
And is it groups?
It depends on what the comorbidity is. It depends on the person and what they have going on. Certainly, we've seen folks who started on a GLP-1, they were pre-diabetic, they started on the GLP-1, it just wasn't in time, and then transitioned to the diabetic category. So it depends on the person, the patient, and their treating physician. And some physicians are a little more aggressive than others in terms of their monitoring. So there's a lot that goes into play with it. Hopefully that answers your question.
Yeah, I think so.
Okay, I'm going to pass it back to Jillian. We're going to talk a little bit about the ancillary programs.
Any other questions on the medical and pharmacy before we move on to ancillary?
One quick question. When it comes to the emergency, if they go to the emergency, what is the cost to our plan? I know if you go, it's $100 deductible, but what does it cost our plan if going to emergency versus the urgent care?
So I think it depends on where they go for emergency. Again, contracted rates vary across between the carriers and what they've negotiated depending on the hospital. Certainly it depends on what the diagnosis and the reason is that they are being treated at the emergency room. So there's a lot of things that will go into that. And then there's also whether or not they become admitted in terms of the claim and how that is passed through the system. There's a lot of factors in what.
The number used to be if it was like $100 for the emergency, it was like $900 to the plan where I
Right.
think with urgent care, maybe it was 15, maybe it was $100. So looking at the financial or whatever, that's what I think is important.
We can bring back
Yeah.
some more detail in terms of what that looks like on average and add that to the deck. We don't have specific stats on that right now, but we'll bring that
Okay,
back for
thank
you. Especially as we begin to get additional data, that's going to be helpful and will give you a clearer picture of what the spend actually is on that front.
All right, looking at the dental and vision plans on the next page. We have it broken out by dental plan, preventive plan in the maroon, the deep PPO buy-up plan in the dark blue, and then combined statistics in the darker color orange there. Your Anthem Vision is in the lighter orange on the far right. In general, the preventive plan tends to run over at a higher loss ratio than the PPO plan, but when we combine them, everything's running right about around 100%, and that's pretty consistent in terms of what we've seen historically. The trends are up a little bit versus the prior 12 months, but still in line with what we see in terms of the preventive plan being the one that's running slightly higher from a loss ratio perspective, and then the DPPO offsetting that for a combined relatively stable trend over time. In terms of what we look for to see in dental loss ratios, the tolerable loss ratio or target loss ratio for the carriers on fully insured plans is around 90%. So right about now, it's running about 10% higher than where we would like it to be. On the vision side of things, similarly, the plans run pretty consistently stable over the plan year to date. And then in comparison to the prior 12 months, target ratio for that type of plan is usually around 83 to 85% for fully insured vision plans.
So how then does this prepare us to think about taking them on as self-insured?
Well, there's some things that are factors in a fully insured environment that aren't factors in a self-funded environment, which kind of automatically results in savings such as, some premium taxes and things like that. The other thing to take into account is that in a self-insured environment, there are years where you're going to win and years where you're going to lose. So when you're self-insured, you can at least take advantage of those years where you win out and the revenue generated by the plan exceeds what the payout is on claims. But and similarly, in the years where it's the opposite, you lose, you pay a little bit extra in those years. So I think for self-funding, it's really a long-term strategy when you see that opportunity to potentially take advantage and participate in the years where it's been a favorable claims experience. But you do also take on that risk. So it's a little more up and down versus sort of a consistent, stable premium.
We've done a look back, I think it's 12 years of data in terms of how the plan is run and taken a slice at the actual spend on a fully insured basis as compared to a self-funded basis. And the city would have benefited being in a self-insured arrangement over that time quite substantially, even with the up and down from a year-to-year basis.
Right. And then the last two, or the next 2 pages, I should say, are your life and disability experience. The first one is your life experience, which is broken down in the same sort of layout as the prior dental and vision tabs. You can see how, from a loss ratio perspective, all the plans are running on a year-to-date, prior plan year, and then since inception basis. Typically for life insurance products, for the basic life, where the target is about a 70% loss ratio. Optional life is around 55%. So they're both running higher than those tolerable loss ratios. So being that they're in guarantee, just something to be aware of and keep in mind as their next renewal approaches. But a lot can change in that time, just given the nature of the way those claims tend to hit. And then on the disability side of things, the short-term disability is running well below the tolerable loss ratio. Long-term disability is plan year to date is running above where we'd like to see it, but over time and since inception, it's right on target with that 60% target loss ratio. So again, in guarantee, so nothing to be too concerned about this time, just something to be aware of for when they do come up for renewal. And I'll pass it back to Megan to close out with EAP.
Yeah, so with the EFAP program, it's running steady at about a 5% utilization in terms of the actual counseling services that are provided. We are seeing about a 22% engagement on the training and the critical incident hours bucket. There is very nominal engagement with their digital platforms, but those that do engage are actually very highly engaged. And on those platforms, we're seeing Calm being used quite a bit, and some of that usage is concentrated in music and sleep soundscape services, which is great. Medication, all of those kind of speaking to kind of what the high utilizing or lead counseling needs are in terms of anxiety. I know I'm less anxious when I get sleep, so that's great to hear that folks are using that stuff. On the Calm and what they're using it for. It is the leading counseling need being anxiety and worry that speaks to that. But in terms of the underutilized services, some of those that are available may also help with that counseling need. So we do see an opportunity in education regarding the services and the value adds that are on the plan that might help with what the population and membership is feeling across the board. So there is an opportunity to educate and on the services that are available. When certainly we are looking at the RFP that's being built right now, we're taking that into consideration, as well as benchmarking the city's plan against like size and industry, and kind of maybe looking at what is offered and looking at alternative offerings as well as options to self-insured. So taking into consideration the utilization as we're working on that RFP that is being developed. So but generally speaking, very normal and as compared to what we're seeing with other entities and clients. And that is just a close out and wrap around of those programs. I'm happy to answer any additional questions that you might have at this time before we pass back.
So before we also continue on the report, I do want to kind of mention, I think what we learned a little bit about this is we still have a lot to kind of investigate and to look at overall what is potentially going to happen with actual specific claims of the carriers before we get to a point of making a decision on what to do for either renewal or going back out to bid. So I think what we'll be doing is still continue to look at claims. We'll be having a lot more discussions over the next couple of months with JLMBC over how things are going, what this is looking like, and what we should be considering for 2028. The committee probably doesn't remember because it's been so long since we looked at it. There are rate cap guarantees for 2028, but they are higher than the ones for 2027. So it is a question of what is our better risk on moving forward and what we want to do. So there's going to be a lot more education, discussion, and analysis that I think we can bring forward.
It'll be helpful to have a full cycle to see what's happening under the program. Certainly, we do usually see a little bit of an uptick at the end of the year in terms of claims around the holidays. Folks tend to get procedures done, but we don't anticipate, hopefully, what we saw this last year in terms of that uptick, but that certainly will be helpful to get the additional data.
I just have a general question. In the presentation, I mean, what key takeaway was one of the things driving costs are these large claims for Blue Shield PPO. And so between the time the committee last met and now, when you worked to look at additional claims data, did that trend continue? And is that why we expect no change in the rates after reviewing that? And are those rates based on the assumption that those high claims are going to continue? Are we going to continue to see those into the next year?
Okay. So in terms of the high cost claimants, and especially on the PPO, the cost, the city certainly benefited from the negotiated rate cap that is in place, because the rate action that would have necessitated would have been higher than what the rate cap is. So that is the first thing. we did have conversations with Blue Shield. Again, it's an immature plan. We don't know if that will continue. We certainly hope it doesn't. But it is immature, and so it's hard to kind of ascertain for them what that's going to look like. We have two PPOs in play here. We have the high deductible health plan and the traditional PPO. And we don't know what the enrollment will look like in terms of the future on either one of those plans and what folks will continue to select. And so the long-term outlook for that, we certainly hope it gets better, but we don't know. So certainly the rate cap has helped the city specifically for that plan in terms of where we're seeing the large claimants come in. Anything to add there, Jillian?
I was just gonna add that the one thing the loss ratio doesn't take into account is the amount of the large claims that will be forgiven in the renewal calculation process. So if you are going to have large claims on your plan, which we hope nobody does, but they're always there, it's best to have them in high severity, low frequency, because it maximizes the pooling effect of claim forgiveness in your renewal. So it's actually better to have a couple very large claimants, because that will be forgiven depending exactly how much will depend on what the experience period is for the renewal, but that will be forgiven when they're doing the calculations for next year. So that should pay off. Also, 3 of the 5 are terminated, 3 of the top 5. So that's also another argument for us when it comes to negotiations, that usually one we expect some to kind of replace them as the plan continues on, but maybe not 3 of that magnitude in, the same time period. So I think the way that they're coming onto the plan is, if they're going to be there, this is the better of the 2 ways versus a lot of relatively low large claim activity. So we'll see once the renewal calculation comes out how it affects it. But in general, this is the most beneficial way to have large claimants appear on the plan.
You're
From a
welcome.
rating perspective.
Does the population size, is that a factor
In the renewal calculation?
when you're dealing with high claimants? It has to be, right?
Sure, you're definitely going to see larger, more, we'll call them ultra high cost claimants in a population of the city size, just because it's a greater sample size. And also it's better because there's, a lot of other people that aren't high cost claimants. So it still represents a relatively small slice of the pie, even though it's a lot of dollars.
But when we broke into 3 providers, doesn't that, increase our risk of cost increase due to high claims? Because now you have smaller, right? Because you have smaller populations in each, or at least in 2 of the 3.
I would say yes and no. They are certainly vying for membership. Again, they're trying to spread their risk and they want the good risk. And so in terms of competition and how they're rating, they are taking that into account. We did see a lot of that during the renewal process, a little bit of jockeying and trying to understand where everybody's coming in at. So we are seeing the competition. In terms of where folks landed, for Blue Shield in particular, the challenge being that a lot of the high cost claimants and a lot of the cost spend are coming on the PPO. They are the one carrier with the PPO. So that is a challenge that remains there with the Blue Shield plan. So in it, again, it just, in terms of where folks landed in the bifurcation of the enrollment, UHC did receive a lot of the folks who were on the Vivity plan because that's who they contract in terms of their network. So they will have some challenges with costs associated there, and how they manage it is certainly something we're going to be looking at. So yes and no. They are still vying for good, healthy membership because that's what they want. So that's the one side of this versus where folks actually enrolled.
And just to add to that, regardless of which carrier they're under, the large claims will exist no matter who's paying the claims. So, and even though it's split between 2 carriers, the enrollment is still a very large group for fully insured medical. So there's a component for smaller group. I might be going on a small tangent here, but there's a component for smaller groups that's called credibility in underwriting. And that's when your sample size of your population is not small enough to be considered fully credible on its own. But the city, so they blend it with what their book of business, but that doesn't happen on the city because the city is such a large group in the renewal calculation. So even though it's split between a couple different carriers, the two groups are still large enough to be fully credible. So they might all be, maybe there's more in one than under one carrier than the other, but the overall impact, it would still be a fully credible situation, whether all with Anthem or split between Blue Shield and UHC. If that helps.
Thank you.
And Kaiser only has the two high claimants?
Their reporting threshold is much higher because their pooling point is over $1 million. So they only report the claimants that have exceeded that. So there's definitely something between, 250 and $1 million, but that's all that they will on in the reports that they provide us.
So we can't really say that there's a concentration necessarily in Blue Shield because Kaiser has their fares of high claimants also. And if that's the case, why is Kaiser coming in at a 6% increase and everyone else is coming in at 13? It doesn't, the math isn't mathing for me yet.
So,
I'm just,
yeah.
it's not really a question.
Okay.
I think the hope is still we get more claims, because the claims experience is still just going through April, May, somewhere on there.
April. Yeah.
April. So I think the hope is still that when we get more claims experience and it's specific to the plan instead of being general to everything, that we will hopefully see what we were expecting to see, but we won't know. Yeah.
Thoroughly.
Is this normal when you change carriers? Is this, you don't have the information or
Yeah.
or background or history to make a
Yeah, in a normal scenario, we would have liked to have seen a transfer of data from the prior carrier to a new carrier. And certainly if it were 1-to-1, that could have happened. With the fact that the data split, there's, getting data from Anthem and to the specific folks just for UHC and to specific folks just for Blue Shield, that they were not able to segregate the data out and provide it to the carriers separately for them to have a better look at what their population actually looked like for on a longer period look back. So that is part of the challenge that we have right now, but certainly on a 1-to-1 basis, we would see this.
There's no other questions on that piece. We'll transition over to the rest part of the report. And I think the best visual place to start is with the testing. For a recap, when we go out to bid for medical plans, the best rate guarantee from a ongoing basis is a 12-month guarantee. We'd love to be able to have longer than 12-month guarantee in premiums, but healthcare is too volatile. And so 12-month is the best we can get. In every time we renew, those premiums are due in the month of April for us to be able to adopt and discuss and then program in for open enrollment. And with that 12-month guarantee, keeping that rate at the same time unchanged from January to December. In each of those proposals, there are often caveats, little small lines that the underwriter provides that says there might be a condition where they want to prompt a change. We have not yet had that implemented yet. Even though it is almost standard practice that there's always some sort of caveat in one of these rate guarantees. And a typical one is when there is a required mandate that must be enforced that would prompt them to want to change their rate and not honor the 12-month guarantee. Because we are a cafeteria plan, and even though we're not required to follow ERISA, we still follow ERISA. If there is a change in rates and it's considered a significant cost change to a member, it creates an open enrollment event, it creates an election event where someone can go ahead and change their coverage because that's not what they signed up for. They signed up to pay $10, they didn't sign up to pay $15, so they should have an opportunity to change. So that is all prefacing what you see on the screen right now. So in June of 2026, the last day of June 2026, Gavin Newsom signed a law creating a managed care organization tax, a MCO tax, intended to supplement money that the federal government is no longer giving California for medical plans. And that tax is to be paid by insurance plans. It's new because it just happened in June. It still needs to be signed over by federal agencies, specifically the Centers for Medicaid, Medicare, or CMS. And until it's approved by CMS, it is not officially a tax and cannot be collected. We went to the carriers and asked, hey, what is your position on this? Are you going to change anything? Out of the 3 carriers, only one, Blue Shield, had mentioned that they were intending to implement the tax immediately if it did come through. And so they went as far as to propose an additional set of rates. Since we're in the position that we're uniquely in this year, where we left the negotiations open, that window is still open to revise rates. We left it open. So Blue Shield did provide revised rates. However, Blue Shield has made it very clear to us that they have no intention on implementing that immediately. They need to see if the tax is actually going to happen. And then, quite honestly, it would be a business decision on them if they wanted to implement it at that time. We still have a couple things to be able to say internally if there is a basis to do so under our contract terms. So there's a lot of moving parts. What is not moving is our programming. That needs to happen ASAP. So the quirky and awkward position that we're in right now is, what do we decide to put on paper? On the screen, the column that says 2027 rates adopted in June are the rates that were originally adopted by this committee last time we met, before this MCO tax concept was proposed. The last column on the right, revised rates with MCO tax, you can see the revisions that were presented to us by Blue Shield should that tax come. So overall, the premiums are not too much different. But when we look at it towards the impact on member, because the majority of the plan tiers that are presented here are fully subsidized already, some of the plans are fully going to be paid by the member should this tax move forward. And that is listed on page 5 of the report, I believe. So you want to go back to that page, you'll be able to see where the tax lands, should it actually get implemented. So the lines in green show where, or the lines that are highlighted in green, if you can tell, show the cost that is being fully picked up by the employee because the subsidy is capped out. So the cost difference per employee, the largest amount would be $14 a paycheck or $344 a year, with a slightly smaller, but not too much, if that should actually happen. So the risk that we take in implementing that now is overcharging someone and then having to figure out how we're going to refund them and what that actually means if it doesn't happen. The risk we take if we don't implement those rates is discussing with Blue Shield if they actually decide to make a business decision on what that means and impacting us administratively. The latter seems like the better risk to take. So we are recommending that we do not implement the MCO tax rates that were proposed, and to keep with the June 2026 rates, and then see what happens. So if there, oh, go ahead.
Question for Keenan. Are you seeing any providers or insurers passing this on in current, any kind of current year?
Not in current year. So the MCO tax adjustment is going to happen for 1/1/2027.
Mhm.
And so, and we work with a lot of carriers at present time. From my purview, Blue Shield is the only one that has put it into rate calculations at this point in time. Some of the other carriers are taking a wait and see position. Because to Paul's point, CMS has not blessed it. There is a chance that CMS may not approve it and something different comes. It's a very interesting spot to be in right now. And CMS does not typically move quickly. So to Paul's point, programming for open enrollment, with the open enrollment being in October, I mean, it could be a case where CMS doesn't look at this until the fall. I would hope that they would opine sooner, because it does put a lot of pressure on carriers and plans here in California. But they're a big wheel, and we are at their mercy as to when they're actually going to look at this and make a decision. And what that decision will be, we don't know. It could be adopt in full. It could be some part thereof. It just is going to depend on what CMS does.
And what we should probably add just for is, I mean, it was a significant cost cut from the federal government for for Medi-Cal costs for California. This tax is not a one-time tax for 2027, 2027. It was proposed as 2027, 2028, 2029. There's lots of roads that could happen. If CMS also denies it, maybe California's gonna try to do something else. Who knows? But we are probably gonna need to talk about this much more moving forward. Outside of the recommendations on here, just to keep abreast of what's happening and how it could impact overall experience and overall cost of the plan. Plural. With what's going on.
If it is approved and does move forward, what actually happens in the plan year? You have to open enrollment for a certain number of employees that would be impacted?
We would only have to do that if there was a carrier that was requiring immediate implementation of that rate. So if there is a rate impact, yes, under IRS regulations for a significant cost change, we would have to open up enrollment. I think it's a question of, do we open up enrollment for one group that's narrowly affected, or we open up for everyone? There could be a strong argument of someone saying, hey, I didn't know that was the case over there. That would change my mind, even though I'm not enrolled into it. That's maybe not as tangible to say, but it is what is safest.
And the staff recommendation is we cross that bridge.
Right. And preferably we don't, but I think there is still a lot going on. There's a lot of speculation that because of the federal administration, that this won't move forward anytime quickly at all. And so we will, it seems to be the wait and see approach is the best approach administratively right now, but it still comes with a risk.
So do we have access to the content of the bill as it was signed? Because I find it kind of hard to believe that it was conceived as a direct pass on to the consumer tax rather than coming out of the obscene profits that health insurance.
The bill is public, and I think I might have corrected the correct link. I believe I could have gotten it wrong, but I think the link that's on page 3 is the correct link to the legend of the bill. It's regular government language though, so it's not a fun read.
And just a point of clarification, the MCO tax is actually, it's new in the sense that it is actually being adjusted. There is a nominal built into your rates right now. It's 19 cents PEPM. It is increasing to $8.85 PEPM. So it is there, but it is very nominal right now. And because of the recent funding issues, that's the impetus for the increase.
19 cents.
19 cents
per-
PEPM. Oh, sorry, PMPM.
oh, per month.
Sorry. Yeah.
Per month.
So,
Mhm.
so it already exists. This is actually just an increase.
Yes.
Okay, I mean, you piqued my curiosity. We're so far down the road now. Why does the federal government get a weigh in on something that the state's trying to do? I'm not understanding why that an agency of the federal government approves or disapproves of it.
It has to do with the way that the funding is set up and CMS weighs in on it. CMS weighs in on a number of things on healthcare front. From a compliance perspective, regulatory perspective, they are the overseer and purview of many things, just as the state has their own agency in the DMHC. So it is part of that process that they undertake.
I'd like to make a motion to approve the recommendation.
All four, just for clarity,
Right.
A, B, C, and D as written.
Yes.
We haven't about C and D yet. Oh, I see.
Second.
Okay, we will begin the roll call for voting. Tony, your vote.
Aye.
Matthew, your vote.
Aye.
Paul, your vote.
Aye.
Patrice, your vote.
Aye.
Janita, your vote.
Yes.
Marlene, your vote.
Aye.
Chad, your vote.
Aye.
Esteban, your vote.
Yes.
And Lisa, your vote.
Aye.
The vote is unanimous. The motion passes.
Okay, we can move on to informational item.
But no,
Benefit provider presentation. Anthem, you are up. Good morning.
Good morning, everyone. Hi, I'm Terry Graff from Keenan, and I'm just here to introduce Anthem. Today, we have Nicole Harbor with us, and we also have Amy Wasson on virtually. And they're going to go through, we saw a little bit, a very high level utilization on the vision plan, but they're going to go into the details of how your members are using the plans and network utilization, materials, frames, that kind of thing. So take it over, Nicole.
We'll jump ahead a couple of slides. They're perfect. So, yeah, that's perfect. Okay, so good morning, everyone. Thank you. We're excited to have the opportunity to present to you today. As Terry said, my name is Nicole Harbor. I'm the account management executive for Anthem. Today, we'll be looking at your 2025 period, so January through December 2025 for your vision plan. We'll look at your membership trends as well as network utilization on your eye exams and frames, lens enhancements, and as well your on-site visit clinics that we support. And these metrics overall will give you a great understanding of how your members are utilizing the plan and the value that the plan brings to your members. So I'll hand it over to Amy Wasson, who's our Director of Product Management.
Good afternoon or good morning, everyone. Sorry I could not be there in person today, but hopefully in the future I will be able to be there in person.
Go back one slide. Perfect, thank you.
So this is your total membership of 55,749, which is slightly up from last year, but very consistent. As I looked at last year's to the 2024 review, all the numbers are very consistent. Your plan utilization is very consistent year over year. The in-network utilization is outstanding at 95.4%, really meaning that your members are finding the providers of choice that they want to go use and are maximizing their benefits by using those in-network providers. Our diverse network does provide a great savings to your members. So the standard network savings is 48%, and the plus network savings is a little bit higher because it's a little bit richer benefit there at 50.2%. And then your overall exam utilization is at 24.4. And, we really want members going in and getting those exams. They provide early detection for different eye conditions as well as medical conditions that can provide, early intervention so that they can get the best outcomes. We can move on. Yep. Go back, maybe. So this is just a breakdown for you of your month-over-month membership, as well as members, dependents, and subscribers broken out there for you on the right-hand side. So we can go on from this one. One great part of our diverse network is we have a large independent network, but we also have a lot of retail options and also online options for your members. So this one's just showing you that 46% of your members went to an independent provider, and then 49% went to one of our retail options that we have for them. So great retail utilization, which is really important, and we'll talk about it a little bit more. This is just reiterating also the 95.4 in network utilization. And you'll see down there under, sorry, I forgot to mention the plus providers. Your plan has standard benefits of $150 frame allowance and a $10 exam copay. But when members go to a plus provider, they pay $0 for that exam, and they get an extra $50 towards that frame allowance. And so your members are utilizing those plus providers 57% of the time, which is up 2% from last year. So again, really consistent. Your members really like that new plan that you implemented a year and a half ago. Well, we can go on. This is just showing you like where they're going to actually within the network. So the left graph is for exams, the right graph is for materials. You see that they're very consistent between, both of those. Still, they're going to a lot of independent, and then the top retailer is LensCrafters, You'll see some of the other retailers listed out there. You know, in addition to these retailers, we also have retailers like America's Best and Sight for Sore Eyes, which are regional retailers, but these are the most utilized retailers that we have. Both LensCrafters and Target are plus providers, so we do see, you know, some extra utilization with those providers. And it's really nice to have that mix of independent and retail because the retail is open in the evenings and weekends, meaning that the city employees and their dependents can go when it's more convenient for them and not have to take time off of work. We can go on. This is just now breaking down materials, and you'll see on the left-hand side, 20% of the membership got contacts, 80% got eyewear. That's very consistent with our book of business. And then we kind of just break out the different types of lenses that they might get. Single vision lens being the highest, multifocal, and then people that need progressive lenses is the third type that we split out there. And you'll see your exams are up a little bit in 25 versus 24. Again, we really want people to go and get those exams. This is where we definitely want to see utilization versus not see utilization. So having great utilization there. I mentioned the extra $50 of towards plus frames. So we kind of split out how many people got a plus frame versus a standard frame at 62%. Your standard frame benefit is $150. And so with plus, it goes up to $200. So you'll also see that, you know, there's a large percentage, 41.7%, that were able to get their frames at that frame allowance that you have, and they're not having to spend additional dollars out of their pocket. And then you can just see over there, we broke down the different buckets of the price points for the frames. In addition to your standard lenses, we have lens enhancements. These are the most popular lens enhancements they have. With the Blueview Vision Plan, lens enhancements have a fixed member cost. So that's again part of our provider contract. So when they go in network, they, you know, have additional savings on those lens enhancements that they might get. So you can see the anti-reflective was very popular, polycarbonate was very popular. Photochromatic is like the transition lenses that turn from light to dark. So those continue to gain popularity. And the last one is scratch coating. And scratch coating on our plan is a $0 copay for members. So it's just automatically included. So always like to see that that scratch coating is getting added to the lenses to help them last longer. And the last thing on my slides is just talking about your vision clinics. You have 4 vision clinics that we come on site with the doctor and materials, and your employees are able to come, you know, at work or come to the location where we're having those clinics. We have the different months listed out there, the total available appointments, the appointments that were actually utilized. We always, you know, continue to work with our vendor IMED that provides these clinics, trying to make sure that all of the appointments are utilized. So when people sign up, they also get reminders that they have an upcoming appointment so that they can hopefully make sure to be there. Because the signups get full really quickly, and then sometimes people don't actually show up for their appointment. So we do a lot of work trying to do the reminders and making sure that all those appointments can be utilized. And then you can just see the exams that were done, and then the number of materials that people purchased at those clinics.
And I'll just add on so you can see that just over 200 appointments were completed with approximately 70% of the available appointments being utilized, which is an increase over last year, just pointing back to Amy's comments around all the work we do with making sure we send out the reminders if there is anyone who can't make an appointment, that we go to the wait list next to make sure that all of your appointments are utilized. You actually have your next pop-up clinic coming up at the Figueroa Plaza next week. And I took a look at the scheduling and all the appointments are full. So that's great news. And we're starting to collect those on the wait list as well. Other examples of pop-up clinic locations in the past has been the Public Works, of course, City Hall East. So we've had some great success over the years doing these pop-up clinics, and we'll have one more in October as well. All right, Amy, anything before I wrap up for the meeting today?
No, that is all.
So you can see for the utilization review today, your memberships remain stable. Members are overwhelmingly using in-network providers, which brings savings to your plan. Your utilization patterns have been consistent year over year. Your on-site clinics continue to drive value for your members. And overall, the 2025 results indicate the vision plan continues to bring strong value and broad access to your membership. I also wanted to note a few things that we're doing for your City of LA plan. We're continuing to offer a $10,000 annual wellness credit through 2028, and that can be used for different wellness communication campaigns for the city. We also support you in creating an email campaign throughout the year. Some of you may have received the sports campaign we did, so eyewear protection, especially for children when they're playing sports. We tied it into the World Cup theme in June, so it was a really nice communication. We have one that's coming up reminding members of their eye exams, their preventive eye exams, and we'll tie that into the back to school theme. And then we'll do one more email campaign right after open enrollment closes up. Some of the hustle and bustle dies down. We'll send one more email campaign as we wrap up the end of the year. That concludes the information we had to share for today. Thank you again for the time to present. Any questions?
I just have an observation on that scratch coding. If it's no cost to the member and only 37% are opting in, or, are they aware that it's no cost to them?
The reason for that is some of the other types of products like anti-reflectives and the photochromatic, they inherently have scratch coating in them. So it's just when people are getting so if you just had a single vision lens and you didn't do any other lens enhancements, then they would add it to it. But if you do any of the other lens enhancements, most of those products have scratch already built into them. So it's inherent in that product.
That makes sense. Thank you.
You're welcome.
And can I ask, how do we choose where the iMed clinics happen, the site?
We work with the City of LA team. We want to make sure that they have enough space available so that we can set up the clinic, have all the equipment and everything set up in advance. And so we work with you all to determine the logistics of which space works best. I know that they have tried to move it around so that different employees have access, but we're always willing to take recommendations if there are different locations you all want to consider. We work with Brianna on the team.
Thank you.
All right. Well, thank you. Appreciate the questions.
Thank you so much. Okay, we are on to informational item number 6, committee report 2027 open enrollment communication plan.
Hey, good morning, everyone. I'm Daniel Powell, Employee Benefits. This is a lengthy report. It is probably substantially familiar to you, so I'm just going to try to go through some of the highlights and some of the changes this year. And I'll stop periodically for questions so we can talk through this as we go. So this report's for open enrollment 2027. That will run from October 1st to 31st, with coverage effective January 1st, 2027. So the headline this year is no carrier changes, all same carriers, some rate changes, some changes for the high deductible health plan, and some recertification processes around the dependent domestic partnerships and the cash and loop program. Sorry. And then one other change here is really trying to expand our Spanish language materials. And so we'll talk about that a little bit in the report. So one thing you might notice is this year's campaign is a little bit better right-sized for the changes contemplated for this year. So last year, big changes, big disruption with Anthem being replaced by United Healthcare and Blue Shield. And so commensurate with that, a lot of outreach at the different work sites. We went to 11 work sites last year with open enrollment campaign, benefit fairs. And this year we're planning to do 5. And the changes this year are also much more targeted and much more focused. And so if you're in the high deductible health plan, you're seeing changes to the health savings account and the administration of that, and you're also seeing a new limited purpose healthcare plan. So there's some targeted communications around that. And just the outreach is going to be more focused and more targeted. And so you're going to see targeted communications toward those high deductible health plan members, the folks with a domestic partner, and the cash in lieu enrollees. Any questions on this so far? Okay. So the timeline here, we've got a timeline on the starting on page 2. That really starts with the July, where the really development began last month, kind of taking us all the way through implementation in January 2027. There's some key dates here. You'll see communications begin late this month or early September. Targeted notices going out mid to late September. And then the package is going out by October 1st with reminders throughout the month. So one thing we did differently last year was that we, in the past, for a long time, the practice was to send these really big 100-page open enrollment packets out to employees. Those were hand-stuffed and hand-mailed and quite costly for just time and resources. So last year, what we did differently was automated mailers that were, essentially mail merged documents that had all the employees' information on it with prospective changes in their options. We did that with general services and it went really well. It was a much smoother process. And so we're going to do that again this year. We'll still have the big open enrollment booklet available in person or at on-site events or on the website. So what employees will receive in their packet this year is that personalized letter that we generate with GSD. There's a bilingual What's New flyer. So one side Spanish, one side English, and then some required legal notices. We're looking to do, Spanish language expansion. Although, most employees are maybe comfortable conversational in English, benefits are really personal and sensitive. You might discuss your benefits with family members who aren't as comfortable in English. It's technical language. So we really want to have expanded Spanish language resources. That's going to start with some kind of basic materials as we just kind of build it out further. It takes time to do all that. And we'll be doing that with our staff in-house who speak Spanish. I'll pause there. Any questions? Questions? Okay. We'll keep going to section B here. So the plan includes 5 on-site benefit fairs at the highest headcount work sites: City Hall East, Fig Plaza, Public Works, Harbor Department, and LAWA. Generally over a long period of the lunchtime hours, we'll have on-site carriers, TELUS representatives to handle on-site enrollment, as well as employee benefit staff. Additionally, there'll be 4 webinars covering just all the basics of open enrollment, site posters, in-person and virtual appointments, and all the kind of routine things you would see during open enrollment. So going to the next section here, like I mentioned, there's no changes to carriers this year, but we are going to be focusing on some of the other changes, like some of the rate changes. We want to make employees aware of those. The change in HSA administration. So employees will have the ability to, make their HSA contributions through payroll, which is a big change, and also the change in vendor from Health Equity to Ameriflex. And then also communicating about the limited purpose healthcare plan, which you're all familiar with. And so those will be some of the targeted communications. But I'll get into the next one that's a bit new. One thing that came out of the dependent eligibility verification audit was that, when someone files for a domestic partnership with us, they may not check in with us if that changed in the future. So what we found in the audit was a lot of those partnership forms were outdated. And a lot of times it was because they married their domestic partner or the domestic partnership ended for another reason. And so what we'd like to do is just an annual process where we have employees sign into a portal that we're creating. It's in-house, where they just recertify that it's still accurate. They don't have to file a form or anything. It's just saying, yes, this is still accurate information. And if it's not, letting us know if the partnership ended completely or if it's became a marriage. And then we, register that and help them register that appropriately. So that's for the domestic partnership. The other recertification has to do with cash in lieu. Kind of in a similar way, when someone enrolls in cash in lieu, they're saying they have medical coverage, maybe from a family member or outside plan, but that could change over time, and we don't follow up and ask if that's changed over time. And so this would be an annual recertification process as well. In the same manner, just signing into a portal and letting us know that that information is still accurate. So I'll pause there. Any questions about either of those processes? Okay. Section F here, the Employee Medical Plan Survey. We've been intending to do a survey for our members, and this was also broached by the Personnel and Hiring Committee. They suggested that they'd like to see the results of a survey. So we are drafting a survey that would be issued mid-September and stay open through the whole open enrollment period. And that's a good time when employees are thinking about their benefits. If they had a change because they were on Anthem before, they'll have time they've had 9 months or so with their new plan to give us some feedback about what they thought of the transition. And so that would be going out next month, and we'll bring a full survey to the committee for review before we do that. So kind of went through a lot there. But overall, there's a little more stability this year, not huge changes to our carriers, and a good opportunity to do some of this kind of administrative cleanup, doing these certification processes, building out, and just trying to provide better resources for employees. So any questions on this report?
Bless you.
Thank you.
Thank you.
Thank you, Daniel.
Thank you.
Okay. On to action item number 7, committee report 2619, Live Well program update.
Good morning, Andrew Torres, Employee Benefits Division. So maybe not quite as lengthy a report, but still a lot in here. So if there's, you're right, if you have questions at any point, feel free to interrupt me, but I'll also stop for questions. The beginning of the report starts with a wellness platform overview for the Personify Health platform. That's the third-party administrator we use for the wellness program. We have used that program now for 2 years. We started back in August of 2024 after transitioning from a different provider. And so that first section is just a reminder of the different resources available through that platform. But what I really wanted to focus on for the report today is and a look at the enrollment and engagement we've seen thus far with the platform over the last 2 years. So citywide, a total of 4,939 civilian employees have enrolled as of June 30th, representing 18% of the eligible LAWell population. Compare that to a government book of business that Personify Health has of 50% enrollment. So we're well under that. And we could talk a little bit about why that is later. But there are distinct department trends, right? So we see that the library, as a department with more than 1,000 employees, maintains higher than average enrollment at 30% enrolled. For departments between 250 and 999 employees, city planning has 40% enrolled. And I go on to mention the CAO's office and the city clerk also demonstrate strong enrollment at 43 and 41% respectively. So a lot higher than the 18% average. Opportunities for improvement are in the Department of Work and Parks, General Services, Airports, Public Works Street Services, and Public Works Street Lighting. All of those are below the average. There may be some questions here, so I'll stop, but I just want to add that we recognize that there's a context there where you're comparing a department of over 3,000 employees at Rec Parks to departments that are much smaller. Any questions on that?
Also, not an issue is that it's the type of classification you're dealing with. Most of the areas where they're high participation are more, professional, administrative, or clerical, or whatever, or in the field, That's a different thing. And it's something we need to look at and maybe to adapt to get to that particular population.
Yes, I'm glad you raised that.
I don't want to follow up his very serious comment with a less serious one, but I just think that Paul's just very hard on his staff. Just kidding. Thank you.
And I'm glad you mentioned that because we recognize that trend exists, right? Where folks that are at this meeting, for example, right, are more likely to be able to participate in a program like this easily because they have access to a computer or they're more comfortable with the app, right? That's the way that the program really is best utilized, is through the mobile app. And that's part of the reason why the enrollment average is so much lower than the book of business average for Personify Health is we're sort of we have one hand tied behind our back because we are relying on sort of generic emails or general emails, I should say, that go out to all employees. But of course, for employees that don't regularly use email, that's not of much use to them. We've supplemented that with postcards throughout the past 2 years, and we're going to continue to do that to make sure that we're reaching all the employees. But one of the asks that staff has for the members of this committee and general managers across the city is to ask us for what resources we can provide to help improve that enrollment for all departments. So that's on the departments. We can also look at enrollment through bargaining units. So our eligibility files are organized employees by MOU, and you'll see that EAA's MOU 1 and 20, as well as SCIU MOU 8 have higher than average enrollment, 33% enrolled. It also varies between department size. AFSCME's MOU 6 and MOU 16 also have high enrollment, even though they're smaller groups. Opportunities for improvement with some of the MOUs with SEIU, MOUs 4, 14, 15, and 18, and AFSCME's MOU 7, and then the building and construction trades MOU 2, all between 4 and 7%. So again, right, probably similar context there in terms of why some MOUs have stronger enrollment than others. Any questions on that?
I guess, and this may not be something you can answer, but I know that you said that like some of the supplemental is sending out postcards and things like that to for people that may be slipping through the cracks. But if the kind of barrier is technology, a lot of times the postcard still just points you back to technology. That's the barrier. Is there anything that like is kind of outside of the scope that is maybe being thought about to be more comparable to them? I don't know if it's like maybe, I mean, I don't know what it would be.
Yes, no, that's a welcome point. I think that so an interesting thing is, like I mentioned earlier, you can use a mobile app, and that's where you get the most out of the experience because you can sync a wearable device if you have one. So that's like a Fitbit or an Apple Watch, and it syncs directly. And so there's a lot of stuff that happens in the background where I don't have to go in and say, oh, I walked, 2 miles today. I walked for an hour today. However, employees can do that manually on the web-based version of the app. So someone can go in, daily or every other day and say, I did an hour walk last night, and so I'm giving myself credit for that. So there are different ways to participate, but your point is well taken that we're still dealing with a program which relies on this sort of internet connectedness.
Talk about how perseverance, you guys. But before he does that, sort of a related question, and I'm going to go back to how we reach people. At least, and if you get a chance to shoot me something on email on MOU 12. For our folks who are supervisors, I have to say, a ton of them do have access to internet and email because it's in their vehicle, but maybe they don't reach it as much as others. I don't know about your unit because that may be less, but so one thing is I do think that we ought to think about it beyond just what is the technical barrier, because I do think there may be some other subtle things that are different in terms of what type of person may want to. I mean, I've always struggled with weight and healthcare issues. So I gravitate towards those things, and then I try to use them on a daily basis. But, frankly, looking at my unit, maybe people could use it and they don't. So my question to staff, or at least challenges, can you come back to us with thoughts about how to reach people outside of either a postcard or an email? Because I do agree with Ms. Igwilder that you all go back, but I will say this. Everybody and their sister has one of these, and it drives me crazy. Some people have more than one of these. And I do find that yeah, it is. Yeah, exactly. And I do find that, for the younger generation, they work off of this more than that. And it drives me crazy. But to the extent that we can push into that, where it's more of a text approach to reach people, because, some people, they'll check their emails once or twice a week, maybe once a day. Other people, they're on this thing every minute. So look at things like that at reaching people as a main tool as opposed to just email. And also think about whether or not it's not just technology, but the kind of person that might jump in it. Because I do think, oddly enough, the more of us that do this sort of stuff, especially in this wellness area, because it would be great to see us, of course, doing it. I'm old enough to know that risk managers did a great job of actually helping employers and insurance companies look at wellness as opposed to just, no, we're only going to pay when you get, my doctor saying, tell me you got a cold and I can't, cover it. But we still have a lot more to go in just helping us all think about how to be healthier every day, which we don't.
Yes.
So I think you might have an opportunity in some areas where you have employees that come in large groups, like I mentioned,
Yeah.
the Civic Center at night, you might have, 40, 50, 60 custodians, or either out to a sanitation yard where you may have, 100 or 200 at one time, versus, with computers, whatever, having something one site. You just to maybe do a pilot
Yeah.
and see how it works, whatever, because, those are really the groups you really need to reach out to.
I
Because
will,
that's where a lot of your injuries and health issues are, especially the type of work they're involved in.
I will also say that, just while we're sitting here thinking, a fair number of our departments, big ones, we have regular JLMCs or JLMs, every month, every quarterly. Tap into those if you want. You can ask us, like, we have at least 3 for sanitation that come up every month. You're welcome. I think it would be great to have you come and just say to people, hey, this is available. How do we reach you? And sort of trigger that interest in it. So those are also places where you could reach our folks that are out there.
Yeah. Take an example, if you take something like say the custodians there at night, so, okay, you can provide them lunch, free lunch.
Oh, yeah.
You have people here.
Healthy lunch.
Healthy lunch.
I'm working on that. I'm working on that. Okay.
And then, you capture their attention, you can have a conversation, whatever, and, and showing them or teaching them how to, cook healthy, or, what's healthy swaps or whatever like that. And, and usually that they will show up.
Yes. Yes. Yeah. Thank you both. My supervisor was just suggesting to me that I also share, it's included in the report, but when we do the in-person outreach, we do tabling events, right? And we experience that where there's some folks where it's, there's some hesitancy, but it just takes that little nudge of like, oh, look, it's pretty simple, right?
Yeah.
Like, don't be intimidated. But there is recognition that we want to do more of that, right? With, people who work alternative shifts,
Yeah.
right? Not
Oh, yeah.
not just in this building. There's a question earlier about the vision clinics, right? And that's something that I've been very focused on in my time here in this on the wellness team, is trying to reach the people that we're not already most likely to reach.
I have a question, because I do see here that you say, city departments and labor organizations can work with Live Well program staff to hold short-term well-being. How do we do that? Like, right now I have a challenge to my members. It's called the 4x4 challenge, and they're gonna, if they complete 4 5Ks that we already have lined up, we pay them for them to run, and a member and a guest. And then we give them something at the end if they do all 4, right? In addition, they get medals and shirts at each race. So how could I incorporate that with you guys? Like, how would that work together with your program?
Yes, so the platform allows us to set up challenges, and we talk about it a little bit in the report here about a World Cup themed challenge that we held earlier this year. I think the easiest way to describe without having a visual here is you can reach out to us, let us know.
To you?
Yes, yeah.
Okay.
Let us know, these are the dates, this is the population I want to reach, and then we can show you what we can do to plug it in. So that it's, they'll get rewarded through the union, but then
Double, because they could use their steps
Exactly.
for your challenge.
Exactly. Yeah, and I know we've been invited to a couple membership meetings. I think it was for one of the SEIU MOUs, and I think some time ago with AFSCME as well. So we're also happy to come to membership meetings. We know that they're not, during office hours, but we have contracted staff through the Personify Health organization that can attend those events.
Good, thank you.
Sure. And then I know we want to get through this in the next couple of minutes. I'll just sort of go ahead. Yeah.
One other thing, sometimes there's an access issue and that's why people don't register or do the platform, but also maybe, it's friction to download an app on your phone. How many more apps do you need? And maybe it's just a issue of the wellness incentive structure. And so one thing Andrew touches on in the report is we're working, I don't know if you know this, but the way the rewards work right now is you earn points in the platform. You can get up to $30 a quarter, and then you spend that within the platform. So you could buy gift cards, you could buy, stuff on the platform, you could buy an Apple Watch. But what we're working with the controller on is changing that model so that the rewards go directly to your paycheck. So that might be a little more of an incentive for employees. And we don't touch on this in the report because we're not ready to share the number, but we're probably going to be able to increase the rewards amount too. And so that would be effective 2027. So between an increased reward amount and having it be straight through payroll, that might be a little bit more of an incentive for somebody to take action and participate.
I think the money needs to be spent because what happens to the money if it's not spent annually?
It doesn't go away annually.
It rolls over?
It rolls over, but there's still a risk if somebody.
General fund, none of it?
No, there is a risk that it can be forfeited if the employee terminates. But Andrew and Brianna, the staff, are really good about telling people like, hey, you left the city, take your money, take your money, take your money. But you're right, they don't have to do that if it's through payroll. If it's through payroll, they'll just get the money directly. The general fund does not get it.
They do good. Okay, I'll trust you, Daniel.
We wish.
And in the last remark that I'll make, and then if there's any general questions about anything in the report, is biometric screenings. So the Personify Health platform contracts with LabCorp to facilitate on-site biometric screenings. And so these are finger stick screenings. So it's kind of like if you ever seen anyone get their blood glucose checked if they have diabetes. It's, as simple as that. And it's read there on the spot with them. They have professionals that are able to provide a brief consultation to the employee about what those numbers might mean, whether they're in range or not. And they're encouraged to follow up with their provider if they have any further questions. So we hosted 3 events in January. They were each well attended. One of the challenges is finding an appropriate size space. So, this room, for example, would be perfectly sized, except for the fact that, we have all these chairs. And so we're very, it's very difficult to find large spaces that can accommodate a lot of employees. And the only reason that having a large space and having a lot of employees at once is important is because fasting is usually recommended for these screenings. And so you can imagine someone might not want to have a screening at 1 p.m., right, if they've been fasting all day. So, when we did it in January, we did appointments from 7 a.m. to 11:30. And, the earlier appointments, people were showing up and happy to participate. But by the later appointments, we had a lot more no-shows. My point with that is just if there are spaces that you all have access to where you'd like us to show up, where we can fit, roughly this size room, we could have 4 or 5 screeners going at the same time and serve a lot more employees that way. But still, right, we acknowledge that we're not going to be able to reach everyone through these on-site screenings. And so that's why we are working with the Personify Health to offer a voucher program where employees right now can go onto the platform and access a voucher to complete the same type of screening at a LabCorp facility near them. At whatever on whatever schedule they have. The important thing to note, though, is there's a distinction where at the LabCorp facilities, it's a full blood draw. It's not just a finger stick. You don't get your results either immediately because it's a full blood draw, and so it has to get sent to the lab. But it is another way that we're trying to provide access to employees. We're going to be supplementing this announcement with an email announcement to all employees and a postcard, including, for example, a phone number that folks can call so they can get assistance with signing on so they don't just have to do it online. Okay. All right. Well, if there's no other questions, thank you. And
Thank you.
Okay, next we'll move on to item number 8. Committee Report 2620, Projects and Activities.
Hi, just Karina and Gabby here to provide you with some quick updates. So jumping right in, Anthem reached out to the city to coordinate the next Vision benefit campaign themed back to school. It aimed to remind members to schedule eye exams for dependents, update eyewear, protect against UV exposure, and reduce eye strain. Also, Employee Benefits and Anthem recently hosted a vision pop-up clinic at the Public Works Building to allow employees and families to receive eye exams and shop for eyewear. While the July attendance numbers are being finalized, like Andrew mentioned, these pop-up clinics seem to be very popular with appointments booking rapidly. And moving on to 2027 open enrollment planning, the open enrollment kickoff meeting was held on June 9th with TELUS. And like Daniel previously mentioned, unlike major changes in 2026, 2027 will see minor plan adjustments, such as rate updates for most plans, administration changes for the HSA, and the introduction of a limited purpose healthcare flexible spending account for HSA enrollees. Staff has begun working on the open enrollment theme, goals, calendar, and deliverables.
Thanks, Karina. So the dev audit is reaching its full-scale action. While initially planned for August, we do expect the dev audit's final results to be reported during the September meeting. During phase 1, Secova reviewed roughly 12,000 dependents with on-file historical documents from the past 5 years. Phase 2 covered approximately 18,000 dependents across 2 groups. So the Secova audit response deadline was extended twice, with the original deadline of July 3rd, which was extended to July 6th. It was then subsequently extended to July 16th. The EBD's audit response deadline was extended from July 9th to July 21st. Approximately 335 employees did not respond by Secova's July 16th deadline. Coverage termination for affected dependents took place effective July 31st. Under EBD's special group audit, staff recently completed the review of the non-responsive group of employees. Staff completed and mailed notification letters on August 4th. This group encompasses approximately 222 employees with a total of 245 dependents dropped. And coverage termination for this group is effective August 10th. Over 500 employees that were part of the phase 2 Secova audit submitted documents that were either incomplete or rejected. They were granted a final extension deadline of August 10th. Employees with removed dependents may submit an appeal provided that they have documentation to substantiate their appeal. And any employee who had dependents removed from coverage through the audit will be able to add their dependents back to coverage during open enrollment, providing that they can submit appropriate supporting documentation at that time. And lastly, regarding staffing, we are actively working to fill one vacant accounting clerk position.
Just one thing on the dev, and you're probably aware of this, but we had folks that had a dependent, like a husband dropped because the husband and kid had the same name, different middle names, but middle names weren't asked. So I don't know how
We did send communication out to those same name dependents to provide extensions to provide those.
Like after the fact?
Yeah,
Okay.
so they are receiving it. We did provide them an extension up until next week. We will say we did do an audit and a lot of them did submit the documentation. So it just had to be applied appropriately to the dependent account.
Right, right. I had someone who submitted, but they were dropped anyway because of the name confusion.
You can provide that to us because we didn't do drops for incompletes, but we can take a look at it.
Okay, thank you.
I don't have anything else.
Thank you.
Janina, at this time, we can add items to the calendar if the JLMBC has any requests.
All right, any requests for a future event, any future agenda items want to be added? All right, our next regular meeting will be on September 3rd. And at this point, we can go ahead and conclude 10:54.
Great.
Thanks for